everyone, this is Dr. Heather Austin Robillard again. This lecture video is going to be another continuum of care, which is inpatient treatment or residential treatment for those individuals with an eating disorder. So as you see on this slide, this is the continuum of care for eating disorders. We've already discussed group therapy, individual therapy, and family therapy. Some other forms of care include transitional living or recovery living, intensive outpatient, day treatment, or sometimes it's referred to as PHP, hospitalization, and inpatient or residential. So this lecture video is going to primarily focus on inpatient and residential, where they are actually in a facility for 24 hours of the day getting treatment for their eating disorder. First, let's take a look at why an individual typically seeks out inpatient treatment. So one of the main reasons could be for medical care. So if they have postural hypertension, which is low blood pressure, maybe they've suffered from some kind of cardiac dysfunction due to their eating disorder, if their pulse is too low or if it's too fast. As we've discussed, eating disorders do have an impact on electrolyte abnormalities. So if it gets to the point where they need 24-hour care, this might be a reason that they would seek out inpatient treatment. Another common reason is if their weight is less than 25% of the ideal weight or the suggested BMI. If binging and purging happens multiple times a day. Again, being in an inpatient or residential treatment gives them accountability so we can help reduce that multiple compensatory behaviors. Another reason they might seek out inpatient treatment is if they've tried other continuum of cares like outpatient treatment or just individual and family therapy, but it has not created any significant outcomes. If there's a need for medical observation, maybe they have another disorder that is actually high risk for them when they have their eating disorder, like maybe diabetes. If there's any kind of suicidal ideation, we want them to be in a facility where they're able to be watched so that we can reduce the potential for them attempting suicide. If for some reason there's any kind of family sabotage, if there are parents in the home that are actually enabling this eating disorder for their own purposes, we might want to get them away from that and into a facility where they can be monitored. If there are some type of increased risky behavior, maybe a substance use disorder or something like that. And then lastly, if they're unable to carry out their day-to-day activities. So when admitting a patient to inpatient treatment center, some of the process information that we will be looking for depends on the intensity and duration of treatment. This duration or intensity can depend on the insurance coverage, whatever their limits are or their ability to pay for treatment, the severity and length or duration of their eating disorder, what their mental health status is, or any coexisting medical or psychological disorders. The health professional on the treatment team will make a treatment recommendation after examining and consulting with the patient as well. Here are some important aspects for treatment. Is there going to be planning, shopping, or cooking meals? That the exercise is according to the client's needs? What kind of leisure activities are available? Does it attend to the spirituality needs of the client? Are there individual and group therapy facilitations? A dietitian is important. A psychiatrist for medical management. That they're participating in outings and real-world situations. And it's based on a level system used to give the client more independence, so they might earn certain privileges based off of some of the outcomes that they've completed in their treatment. While not every inpatient treatment center is the same, many of them have similar goals, including medical stabilization. Another goal is usually weight gain, especially for those who are participating in anorexic behaviors. a cessation of binge eating or any compensatory behaviors like vomiting or laxatives or overexercise, or any other unhealthy behaviors that are used to control their weight or their shape. There's typically a normalization of eating through a balanced and sufficient meal plan. They tend to have therapeutic exploration of any underlying issues that may contribute to their eating disorder, as well as developing skills for affect regulation and interpersonal relationships, and the initiation of a process for comprehensive social and vocational rehabilitation. So, getting them prepared to go out into the real world and function on a day-to-day basis. For inpatient treatments, there are some therapeutic modalities, or these are the theories behind their treatment forms. Most often, inpatient are multimodal, which include several different types of theories like cognitive behavioral therapy, group approaches, interpersonal therapy, family therapy, motivational interviewing, dialectical behavioral therapy, body image therapy, or different art or music therapy, and then experiential or possibly rote course therapy. Here we'll look at the different criteria that needs to be met for treatment setting and levels of care. For inpatient care, a patient is medically unstable based on unstable or depressed vital signs, laboratory findings that present acute health risks, complications due to any coexisting medical problems such as diabetes. The patient is psychiatrically unstable, as in they have rapidly worsening symptoms of anxiety or depression, or suicidal and unable to have a contract for safety. For residential care, patient needs to be medically stable and requires no intensive medical intervention, and the patient is psychiatrically impaired and unable to respond to partial hospitalization or outpatient treatment. For partial hospitalization, the patient must be medically stable, but the eating disorder impairs their functioning without immediate risk. They need daily assessment of psychological and mental status. The patient also needs to be psychiatrically stable, but is unable to function in normal social, educational, or vocational situations. And they engage in daily binge eating, purging, fasting, or limit their food intake, or any other pathogenic weight control techniques. For intensive outpatient or outpatient treatment, the patient must be medically stable and no longer needs daily medical monitoring. The patient is also psychiatrically stable and has symptoms under sufficient control that allows them to function in social, educational, or vocational situations and continues to make progress in their recovery. Let's take a look at some of the effectiveness of treatment. There is limited research on the effectiveness of inpatient and day hospitalization treatments for eating disorder. The current existing studies are small and they are not controlled studies. The focus should be on three factors: the engagement of clients, the effectiveness, and relapse. When it comes to engagement, few clients agree to inpatient treatment or day hospitalization options, and there are high dropout rates. Inpatient treatment is effective when it comes to weight restoration. However, it is no more effective short-term or long-term than any other treatment modalities with patients who do not have medical risks. Day hospitalization has shown to be strong and cost-effective as a standalone treatment. When it comes to relapse, inpatient treatments have a high relapse rate for adults with an average of 30% relapsing, and for teens with 9% average rate of relapse. What can we take from this is that inpatient or day hospitalizations are not a cure-all, and we need to consider step-down treatment approaches after they've discharged from inpatient treatment. With this, I want to talk about enteral feeding. Some individuals refer to this as force feeding. It's a highly controversial topic and often takes place in hospital settings that may include things like nasogastric tubes or IV nutrition. In residential or day treatment settings, this may be the process of earning privileges due to finishing meals. It could also be referred to as home-based refeeding, like not leaving the table until the meal has been finished. Refeeding may be a critical step to treatment. Why do you think this would be okay to do to an individual? It might be because their low weight impairs their cognitive functioning, or that the eating disorder thinking impairs their logic, reason, and happiness. This concludes the lecture about inpatient and residential treatment, which takes place in a facility. As you can see, there might be some benefits of having monitoring 24 hours a day for individuals who struggle with eating disorder. However, we need to remember that because of the relapse rate, there needs to be aftercare that includes accountability and helping them navigate life outside of a facility.